Good morning to all, and welcome to the medical clinical meeting this morning. So we have a list of 6 interesting cases for presentation. For the first presentation, I invite Dr. Monica from Medicine 1 to do the first case on Cryptic.
Good morning, everyone. I'm going to present on behalf of Medicine 1. My topic is Cryptic. So this is a history of 46-year-old man, Mr. A daily wager from Tirupati. He has come with the complaints of fever for past 2 months. So he was apparently normal before June and started to develop history of high-grade fever with chills and alternative days. Function CNS examination, only he's drowsy, awakeable with a loss of nasolabial fold in the right side, and in the right side he has a hypertonia, and power in the right upper limb is 4/5 and lower limb is 3/5. All the reflexes were 2+, and planned as a bilateral mute, and he don't have any meningismus or his skull spine all normal. CVS SNST here with the pansystolic murmur in apex, radiating left axilla. Murmur is here all over the area. And he also has a hyperdynamic apex. And RS and abdomen is normal. So this is summarizing a 45-year-old man presented with syndrome complex of fever with multi-infarcts followed by intraparenchymal bleed with underlying valvular heart disease and diabetes mellitus. So differential we consider initially is infective endocarditis and CNS infections, disseminated tuberculosis and vasculitis. So this is the initial CBC. It's a hemoglobin of 9.2, WBC 35,400 with the toxic neutrophilic leukocytosis, mild toxic changes. And this LFT is normal, and sodium is 114 and potassium 3.7, bicarbonate 22. LFT is normal and rapid BBS is also negative. So we have done a CT brain, which has shown an intraparenchymal bleed with 52 HU in left parietal region with surrounding hypodensity and mass effect in the form of effacement of the sulci in the parietal, occipital, and temporal regions. And there is subtle hyperdensity noted within the left ventricle. And he has a midline shift of 5 mm and mild mass effect in the left capsular ganglionic region. So we have done an echo next. So it has showed a flail AML with thickened mitral valve leaflets, and there is no clot or vegetations. So his blood culture, we have done a 3 blood culture, which has grown, first blood culture, which was reported yesterday, which was grown Abiotrophica defectiva, and the subsequent blood cultures were no growth. So MRI brain has an acute to subacute left parieto-occipital hematoma with intraventricular extension, mild mass effect, and midline shift as described. Focal area of intense post-contrast enhancement is seen within the hematoma, which lies in close relation to a cortical branch of left MCA. So as the suggested history of fever, this finding is highly suspicious of mycotic aneurysm with rupture and bilateral cerebellar chronic infarcts. So based on the Duke criteria, he does not satisfy any major criteria, but he is satisfying minor criteria with fever, underlying cardiac condition, and he has infarcts and mycotic aneurysm. And if the blood culture doesn't satisfy major criteria, it's like minor criteria is 4. So he is diagnosed to have probable infective endocarditis satisfying 3 minor. I want to talk about 2 points about Abiotrophica defectiva. It is a facultative anaerobe. It's a gram-positive cocci belonging to Streptococcus family. So initially it was told us it's a nutritionally variant Streptococci. So it causes ocular infection, arthritis, sinus infection, and osteoarticular and prosthetic joint infections, cerebral abscesses, and meningitis, pancreatic abscesses. So among this, endocarditis is the most common disease caused by this microbe. And it's like 5% of endocarditis caused by this microbe. And most often it's culture negative, and it commonly occurs in underlying heart disease. Why it's culture negative means it needs a special nutrients called pyridoxal. Mostly it's available in the human blood. However, otherwise we can, in the subculture, we can supplement with 0.001% pyridoxal and 0.01% L-cysteine sustained growth. And even in our microbiology, initially they reported as gram-positive cocci in past. While we called and asked what's the organism, they told we saw the organism in the smear and we are unable to cultivate it. So this is the colonies of Abiotrophica defectiva, the chocolate agar plate, right side, which has a sparse growth, and the left side, and in the blood agar, it has a so in the chocolate agar, it has a good growth, and in the blood agar, it has a poor growth due to the lack of pyridoxal phosphate. According to AHA guidelines, 2020, so what are the indications to have a surgery in infective endocarditis? So persistent bacteremia or fever lasting 5 days after onset of appropriate antibiotic therapy, recurrent emboli, persistent vegetation despite appropriate antibiotic therapy, and left-sided valve infective endocarditis who exhibit mobile vegetation 10 mm in length without clinical evidence of the embolic event. So how to treat this mycotic aneurysm? The main surgical aim is to remove the necrotic and infected tissue. So there are 3 types. One which is aneurysm excision and ligation without arterial reconstruction. So in this, we will excise and all the necrotic tissue, and we will suture the end to prevent slum blowout. So in other cases, excision with immediate reconstruction. This has an increased risk of reinfection and endovascular surgery. So this is the ESC guideline 2023 as the antibiotic regimen for the this Abiotrophica. So it shows antibiotic recommendation includes penicillin G, ceftriaxone, or vancomycin for 6 weeks combined with aminoglycoside for at least in first 2 weeks. So they also show it has a prolonged course and actually larger vegetation and has a higher rate of complications and valve replacement around 50%. So these are the two case studies on infected endocarditis due to abiotrophica defectiva and feared complication in a competent person. In this patient who is a smoker who used to smoke and drink alcohol, he in the course of admission in the hospital, here he developed proximal brachial artery occlusion. So after the vascular surgery intervention, he has improved. In this patient, he has a mesenteric arterial branch pseudoaneurysm, splenic infraction, and renal infraction. So learning points is about abiotrophica defectiva and what are the indications to do surgery and treatment for mycotic aneurysm. Our patient is getting treated by vancomycin and ceftriaxone. For the neurosurgical intervention, we are planned to do a DSA today, and we are planned to do a TE for him, but due to the increased intracranial pressure, we deferred it as of now. So.
Thank you for the interesting case. So this patient has no vegetations.
Yes, like in the transthoracic echocardiography, it does.
Are there any cases of any reported without vegetations?
Yes.
Without vegetations? Yes. Okay. So how long will you treat the patient?
6 weeks.
At least 6 weeks. The other question is, what are the risk factors he had for?
He's an alcoholic, and other risk factors he doesn't have anything. It's a commensal in the oral cavity, maybe to the alcoholic and loss of consciousness would have got it. And he also has a valve disease.
Okay. Any questions from the floor or online? Okay, thank you, Monica. The next is a case by Dr. Amos from geriatrics. The hunter gets hunted. So I'm running with this laptop this morning.